Welcome to the Deep Dive, the show built for the learner. Whether you're prepping for rounds, catching up on the literature, or just looking for a fast, structured path to expertise. Today, we're doing a mission-critical review of diabetic kidney disease, or DKD. We've pulled apart the key sources to make sure you walk away with true clinical understanding.
And this is so essential because DKD isn't just some common complication, it's a global public health crisis. It is the leading cause of chronic kidney disease, CKD, and end-stage kidney disease, ESKD, worldwide.
The number one cause.
The number one. We know that roughly 30 to 40% of all people living with diabetes will develop this. And to really underscore that impact, our sources show DKD deaths accounted for a staggering 34 to 36% of all CKD-related deaths back in 2017.
Wow. Okay, so if you manage patients with diabetes, you really have to master DKD.
You absolutely have to.
So let's unpack this. We're going to cover everything from the historical recognition of the disease all the way to the most advanced drugs hitting the market right now. Where does this story even begin, this link between sweet urine and kidney failure?
Well, we're talking ancient history here. Diabetes was recognized as early as 400 BC by the Indian physician Sushruta, who called it madhumaya, which means honeyed urine disease.
Okay.
But what's truly insightful is that around 150 AD, the Greek physician Eratosthenes of Cappadocia, he already saw diabetes as primarily a disease of the kidney.
Really? That early on?
That early.
Yeah.
He basically thought the kidney couldn't retain fluid, which led to all the wasting and decline. So for centuries, the two were clinically linked.
That's incredible. The recognition was there way before we understood the physiology, but I guess the real game changer wasn't just knowing the connection, it was developing a tool to measure the damage early.
That was the pivotal breakthrough. It came in the 1950s with Rosalind Yalow and Solomon Burson, who developed the radioimmunoassay technique. Before this, you could only measure huge amounts of protein loss.
Frank proteinuria.
Frank proteinuria, exactly. This new technique let clinicians detect, minute concentrations of proteins, specifically albumin, in the urine.
So measuring something that was basically invisible before.
Precisely. And in 1963, using this new sensitivity, researchers led by Harry Keene showed they could detect these tiny amounts of albumin excretion, well below the conventional threshold, in diabetic patients who were otherwise asymptomatic.
And that must have been a revelation.
It was a total revelation. It gave us an early warning sign. And this is where the concept of microalbuminuria was born. It signaled damage long before the GFR started to plummet.
So now that we know how to spot it, let's talk about the sheer scale of the patient population we're dealing with.
The scale is, it's almost overwhelming. Global diabetes prevalence was 9.3% in 2019, but the projections show it surging to nearly 11% by 2045.
And where is that prevalence concentrated?
That's the crucial part for clinical practice. DKD prevalence jumps significantly in older cohorts. It hits almost 20%, 19.9% in those aged 65 to 79.
Which immediately brings up a huge clinical challenge. Managing DKD in the elderly. I mean, they have so many more comorbidities, more frailty.
That's the nuance that gets lost in simplified guidelines. The truth is, almost all the major clinical trials, the ones that establish the benefits of aggressive metabolic and blood pressure control, they were done in younger, healthier, middle-aged cohorts. Right. So when we apply those guidelines to an 80-year-old patient with multiple cardiovascular risks, we're often extrapolating. A rigid HbA1c target might actually be inappropriate, even harmful.
So you need a whole team.
You need a whole team. Sure. It's why geriatric DKD demands a multidisciplinary approach, not just a nephrologist and an endocrinologist, but often a cardiologist, a nutritionist, even the podiatrist, everyone coordinating care.
That sets the stage beautifully. Let's bring this down to the clinical floor now. How do we actually diagnose and screen for this in a standard practice?
DKD is primarily a clinical diagnosis. It's based on two key metrics that are persistently abnormal: increased albuminuria and agar-air, a reduced eGFR.
And I imagine the patient's history is a big clue.
A huge clue, especially the duration of diabetes. In type 1, DKD usually doesn't show up for at least 10 years. With type 2, though, we can see it present right at the time of diagnosis.
And the gold standard for screening is the urinary albumin to creatinine ratio, the UACR. Let's make sure our listeners have those thresholds down cold.
Absolutely essential. It's measured in milligrams of albumin per gram of creatinine. So normal is less than or equal to 30. Moderately increased albuminuria, what we used to call microalbuminuria, is 30 to 300.
The early warning stage.
The early warning stage. And severely increased albuminuria or macroalbuminuria is anything over 300.
And there's a practical tip here, right? You can't just use one sample.
A crucial tip. Albumin excretion varies so much day to day. You cannot diagnose based on a single sample. You have to show it's persistently increased. That means 2 out of 3 specimens collected over a 3 to 6 month period have to be abnormal.
Okay. Let's pivot now to the engine room, the core pathomechanism. We mentioned hyperfiltration. Why is this sustained excessive filtration so destructive over time?
Hyperfiltration is the central crime. In the diabetic state, thanks to chronic hyperglycemia, the individual filtering units, the nephrons, they just start working overtime. They're hyperfiltering.
Like an engine running in the red all the time.
Exactly. And it causes 2 big problems: single nephron hyperfiltration and hyperreabsorption in the tubule. This sustained excessive pressure physically stretches and damages the glomerulus. It leads to thickening of the glomerular basement membrane and expansion of the mesangium, the supporting tissue.
Which leads to scarring and permanent nephron loss.
That's the end game.
Yeah.
Scarring and permanent loss. So reducing that single nephron hyperfiltration, that is the modern therapeutic goal.
That perfectly sets up the explanation for our newest drugs. How does an SGLT2 inhibitor, which targets glucose transport, actually manage to relieve this destructive pressure?
It's an incredibly elegant piece of sort of rediscovered physiology. Normally, the sodium glucose cotransporter 2, or SGLT2, is a workhorse. It reabsorbs about 97% of all filtered glucose and sodium in the very first part of the proximal tubule. In diabetes, SGLT2 activity just goes into overdrive to handle the high glucose. And that means it over-reabsorbs glucose and, critically, way too much sodium.
So the signal for the kidney's pressure-regulating system gets lost.
It gets completely lost. If there's low sodium delivered downstream to the macula densa, which is the sensor, the kidney thinks, oh, we must have low systemic volume. So it tells the afferent arteriole, the artery going into the filter, to relax and dilate to increase filtration.
And that dilation is what causes the hyperfiltration.
That's the hyperfiltration right there. So when we give an SGLT2 inhibitor, we block that over-reabsorption, we force more sodium to get delivered to the macula densa, and that restores the tubulo-glomerular feedback mechanism.
So the kidney finally gets the right signal again.
It gets the right signal. The macula densa senses the increased sodium and signals the afferent arteriole to constrict. That constriction reduces the pressure inside the glomerulus, relieves the hyperfiltration, and ultimately slows down that physical wear and tear.
That is a phenomenal explanation. Now let's talk about the other major hormonal system in the kidney, the RAAS system, which we target with ACE inhibitors and ARBs. Our sources mention something novel about RAAS in diabetic kidneys.
Yeah, this is fascinating, and it's a point of potential resistance to our standard therapy. In diabetic kidneys, there's evidence of a compensatory shift. The kidney can actually move away from the traditional ACE-dependent way of making angiotensin II.
It finds a workaround.
It finds a workaround. It uses a non-ACE-dependent pathway. It uses different enzymes like serine proteases. Chymase is a big one, to generate angiotensin II.
What's the clinical implication there? Does that mean our ACE inhibitors aren't working as well?
It raises the question of whether a traditional ACEI or ARB by itself can fully block the destructive effects of angiotensin II. It suggests that even with maximal RAS blockade, some patients might still have damage driven by these alternative pathways. And that helps explain the rationale for combining RAS blockade with other agents.
Perfect transition into modern management. Let's talk about the bedrock of DKD treatment, starting with glycemic control. Targets have to be individualized, and there's a pretty sobering history here.
We have to remember the lesson of the ACCORD trial. While TEC control is good, the recommended HbA1c for most patients is less than 7.0%. But for those with advanced CKD or a high risk of hypoglycemia or limited life expectancy, we deliberately recommend liberal targets, often less than 8.0%.
Because ACCORD showed that going too low could be dangerous.
Exactly. The trial showed that aiming for an HbA1c below 6.0% actually led to increased mortality, and it had to be stopped. It's a huge clinical reminder. You have to balance long-term benefits against the immediate serious risk of hypoglycemia.
Beyond glucose, what are the twin cornerstones of therapy that have been standard for decades?
First, ACE inhibitors and angiotensin receptor blockers, or ARBs. Their benefit is proven, especially for reducing proteinuria, and it often seems to be independent of their blood pressure lowering effect. We call that renal protection. Second, aggressive blood pressure control. That's non-negotiable.
What are the targets there?
KDIGO guidelines set targets of less than 420/90 for non-albuminuric patients, and tighter control, less than 30/30/80 for those with albuminuria.
Okay, now let's get into the three modern advancements that have totally changed the trajectory of this disease, starting with SGLT2 inhibitors. Why are these now considered first line?
They've really earned that spot. They're usually used with metformin as long as the eGFR is over 30. And they're first line because they tackle that core hyperfiltration mechanism, they give impressive cardiovascular protection, and they reduce albuminuria.
But there's a key point here for the learner. A lot of practitioners get nervous when they start these drugs.
They do, because there's an expected transient drop in eGFR, usually about 4 to 6 millimolin.
So how should a clinician interpret that initial drop?
They should see it as a functional and often positive sign. It means the glomerular hyperfiltration pressure has been successfully relieved. It's a functional change, not structural damage, and it's usually reversible. The long-term benefit of stabilizing the GFR decline far outweighs that initial temporary dip.
Moving to the second new class, the GLP-1 receptor agonists, like liraglutide and semaglutide. They also showed some surprising renal benefits.
They did, and what's so fascinating is that the benefits seem to be independent of their glucose-lowering effects. Trials have shown significant reductions in new or worsening nephropathy, mostly driven by preventing new-onset microalbuminuria.
So what's the mechanism?
It seems to be more than just blood sugar control. These agents have direct anti-inflammatory and anti-fibrotic effects in the kidney. They offer a layer of protection that RAS blockers and SGLT2I might not fully cover.
And finally, the newest pillar, the nonsteroidal mineralocorticoid receptor antagonists, specifically finerenone. What gap does this drug fill?
Finerenone fills the need to target the residual inflammation and fibrosis that just keeps going, even when glucose and blood pressure are controlled. Older drugs like spironolactone carried a big risk of hyperkalemia, especially in CKD, which limited their use.
But finerenone is different.
It's different. Being nonsteroidal, it gives you that anti-inflammatory benefit with a notably lower risk of hyperkalemia. In patients with CKD and type 2 diabetes, adding finerenone to a RAAS blocker showed powerful results. An 18% lower risk for kidney failure and a 14% lower risk for adverse cardiovascular events. It's a major advance.
This combination approach is really the modern standard. Let's shift our focus to clinical complexity now, because DKD rarely exists in a vacuum.
That's the reality of the clinic. The overlap is massive. You'll find hypertension in 67 to 90% of DKD patients and obesity in about 35%.
And there's a key correlation to watch for, right, between the eyes and the kidneys.
Yes, the link between diabetic retinopathy and nephropathy, the sources are clear. The severity of retinopathy correlates closely with structural changes in the kidney, like the thickening of the glomerular basement membrane. If you see severe disease in the eye, you need to be extremely aggressive in managing the kidney.
Let's discuss a really high-stakes emergency. Managing diabetic ketoacidosis, DKA, in a patient who already has end-stage kidney disease and is on dialysis. This is a total deviation from standard protocols.
It's a completely different physiological environment. You have to be extremely cautious. In a typical DKA patient, osmotic diuresis leads to massive fluid loss. In an ESKD patient on dialysis, that key feature, osmotic diuresis, is absent. They can't excrete fluid.
So their primary risk isn't dehydration, it's rapid volume overload.
Exactly. The priorities flip. First, insulin infusion is paramount. That shuts down ketone production and drives potassium into cells. Second, fluid management. If they're truly hypovolemic, you use low-volume isotonic saline, but you have to reassess constantly to avoid pulmonary edema.
And what about dialysis?
Crucially, unless the patient has severe hyperkalemia or acute fluid overload, you typically hold hemodialysis. Dialysis itself can complicate things, and often the DKA can resolve with just insulin and careful fluid management.
Looking to the future, what's being explored beyond our current markers like albuminuria and eGFR?
Researchers are hunting for earlier, more specific indicators of damage. We're looking at tubular markers like NGAL and KIM1, which reflect direct damage to the renal tubules. We're also studying podocyte markers like nephrin and podocalyxin, which indicate injury to the specialized cells of the filter itself. These might let us diagnose at a truly preclinical stage.
And speaking of innovation, we have to mention the complex story of bardoxolone, a drug that looked promising but ran into safety issues.
Bardoxolone is a perfect case study. The drug was effective at increasing eGFR by an average of 5.5 millimolin versus placebo in the Beacon trial. It looked functionally successful. But that trial was halted early because of a significant increase in cardiovascular events, specifically heart failure in the U.S. cohort.
Why the disparity in outcomes?
Well, heart failure is already a huge competing risk in CKD patients. The drug's mechanism causes some mild volume expansion, and that likely pushed these already vulnerable U.S. patients into frank heart failure. Interestingly, a later study in Japan, the THU-ABACA trial, reported more favorable safety results in a cohort with fewer baseline cardiovascular risks.
So it highlights how crucial the patient population is in these trials.
Absolutely. You have to customize trials to the specific risk profiles of the regional population.
Before we wrap up, let's talk system level. How do we make sure every patient gets this complex, multidisciplinary care?
We need to rely more on technology. Specifically, computerized clinical decision support, or CDS, systems integrated into electronic medical records. A good CDS system should identify high-risk patients, adjust drug dosing based on eGFR, and prompt providers to order the right screening tests.
But the challenge is alert fatigue.
The massive challenge is alert fatigue. Providers just start ignoring constant pop-ups. Future systems need to use customized, risk-tiered alerts that only trigger for the most urgent needs.
And one final crucial caveat about everyday prescribing medications that aren't for diabetes but can still injure the kidney.
Vigilance is key. Providers have to watch serum creatinine when starting any new drug. Common medications like NSAIDs, proton pump inhibitors, even certain antibiotics can all cause acute tubulointerstitial nephritis. This adds an inflammatory insult to an already vulnerable organ and can accelerate DKD progression.
So if we look back at this whole journey, what is the final critical takeaway for the practitioner managing DKD today?
The main takeaway is that DKD treatment is no longer passive. It's a highly effective, active, multi-pronged intervention. It's built on that foundation of glucose and blood pressure control and RAAS blockade, but it's fundamentally changed by these innovative medications, SGLT2I, GLP-1RAs, and nonsteroidal MRAs, that actively target the underlying mechanisms of hyperfiltration and fibrosis.
The prognosis is just better now.
The prognosis is significantly brighter. We have tools that target the disease at a molecular level.
And here's where it gets really interesting and where the research is headed. The ultimate goal isn't just slowing progression, it's structural reversal, actually fixing the damaged filter. While our current therapies are great at slowing things down, achieving true, measurable reversal of that scarring remains controversial.
It's the holy grail.
It is. Researchers are looking into pathways like leptin signaling as a potential avenue to force that structural repair. And that is the frontier for the next decade of discovery. To leave you with a final exercise to reinforce what we've learned today and make sure you can apply this immediately. For a 68-year-old patient with type 2 diabetes and stage 4 CKD, that's an eGFR of 25 LLmin 1.73 ml/2, who is already on maximally tolerated ACEI therapy, describe the two key therapeutic classes that represent the latest advancement in reducing their risk of kidney failure and adverse cardiovascular events, and state the individualized HbA1c goal range recommended by major societies for this specific patient profile.